I am thrilled today to have Dale Ellicott with me. He began his career in athletic training, developing a strong foundation in patient care, recovery, and performance. He then transitioned into neuro device sales, where he partnered closely with clinicians to support complex neurological rehabilitation and outcomes. Dale later spent time at Health South, working within inpatient rehabilitation and engaging in bundled payment programs that aligned to clinical quality with financial performance. His experience continued to evolve into digital health and telemedicine, helping organizations extend care beyond traditional clinical settings. Today, Dale combines his diverse background at Rely Health to help health systems better connect patients to the care they need when and where it matters most. And for the listener out there going, wait a minute, this doesn't seem like our typical guest. Why does Andrea have Dale on today? I want to share with the listeners that Dale has actually helped me understand how innovation and AI can make our clinician lives better. And he gave me some advice earlier this year that I'm happy to say has proven to be quite fruitful. And I'm happy to share with the audience that after 10 years of being in medicine, I'm getting my first funded grant in part due to Dale's advice. So, one, I just want to thank him. And two, I think a big part of this podcast is understanding that physicians frequently don't have the answers and that we have to work more with people of different backgrounds to understand where technology and innovation can be advantageous. So, with that, Dale, welcome to the podcast.
Thank you. I'm glad to be here.
You've had a variety of professional roles, and you are definitely somebody that's a change maker by definition. What you're doing with Rely Health, which we'll get into more, and the innovation happening there is change making work. How did you enter the change making arena?
I think there was probably two transitions. So one, as you mentioned, started off as an athletic trainer, moved over to the dark side, as many people call it, and got into business development and sales in the healthcare world. But it was really the first time I joined a device company. It was newly approved FDA technology for actually electrotherapy for dysphagia. And my job was to go in the room and teach the electric therapy part of a course while we had an occupational therapist there that was teaching about the swallowing mechanism and how it can affect. Walked in super excited, was really excited to teach everybody something new, and just realized how challenging that might be within the first few minutes. There's a room of 50 clinicians. They were taught their entire career that this was contraindicated. You should never do it. The only thing you could do for swallowing disorder after a stroke is compensatory mechanism. So go through this whole course, and to say the least, the room was cold. They were not real excited to hear that, hey, I was telling them this new thing and they could do all this new stuff. And somebody pulled me aside later and just said, we're not upset with the technology. We're excited about that. We're not upset with the change. However, we're sitting here thinking of all of these patients that we treated throughout our careers that we told there was no way to recover, right? And most of the therapists left, maybe not disgruntled, but not real happy with the idea that we were trying to change everything they did. But there was two or three of them that came aside later and wanted to explore more, wanted to get started. Quickly realized there, hey, you're not going to get everybody in the first shot, right? But if we can get one or two of those therapists, one or two of those clinicians to adopt new practices, we can slowly get that flywheel going and make some change. So a lot of emotions throughout that first day, from, oh my goodness, what did I do? This is going nowhere, to, okay, wait a minute. I think we have something here. Also helped me understand the pace that healthcare moves. Not everybody is going to jump right on board with new technologies. They've seen a lot of them. That was definitely an interesting experience there. The second one, much shorter story, was working with a skilled nursing facility, doing business development for 18 facilities in Colorado. And moving along, our territory was doing great. We were bringing patients in. And then all of a sudden, somebody asked me, simple question: would you put your mother in that facility if it was your choice? And I just froze. And I hadn't thought of it that way. And the answer was no. There's a much better facility right down the road that we compete with. And that got me thinking more about the process that I use and how to work with patients, and really guides almost everything I do. Looking for the same care that I would want my parents to have if I wasn't able to support them throughout that journey.
Wow. Listening to that last story, what comes to mind is this journey that so many of us go on, that it sounds like you were confronted with a values question.
Yes.
What were your values? And so did that make you go back to the company you were working for and say, there's some things we need to change? Or did you end up leaving and moving somewhere else that you felt was more attuned?
Yes, on both. Went back to the company, said there are some things to change. They said, great, you don't have any budget at all. So if you can do it with $0 investment, make all those changes you can. And shortly left after that.
Yeah. It's interesting because that really shows what came out of the research that I did on healthcare change makers. Is it's not enough to have an individual. That's part of it. So all change begins with an individual transformation. And you also need a system that is going to support you and provide the resources and all of that. I think you've been around technology in a lot of different companies for a while, and healthcare. And a pattern often, I was actually just on call with somebody where this issue came up, that often we're asked to bootstrap something. So you're not going to get more protected time. You're not going to get a bigger budget. But if you can bootstrap this and prove that it's of value to this company, then we'll give you more resources. How have you navigated problems like that? Or also, what have you observed with clinicians in those situations?
From the business side, we call it pilotitis. We have to be very protective of our time and the time and effort we go in. We love exploring new options with clinicians. We love going through the process. But the biggest mistake most startups make, most salespeople in healthcare make, is they think interest is going to equal business. And that doesn't happen very often. So there's a lot of foundational work that has to go in. And it's great that you have clinician champions, people that want to try it and want to do it, but doing the hard work up front, asking them to introduce you to the CFO or whoever holds the purse strings at that particular facility, and whoever can actually commit to, if we hit these metrics in the pilot, then we will fund this and we will move forward, and getting that commitment up front. So that's one of the biggest learnings throughout all the different technologies I've helped develop and try and sell, is that the ideas are great. People want to use them, but you have to work through the system as well. So getting a little bit too excited about having a champion that wants to try your product can lead to a lot of pilots that end up going nowhere. So it's really finding those change makers that are willing to put themselves out there and connect you with the leadership that will ultimately end up making the decision on finances.
Yeah, I'm learning that lesson right now. And thankfully, I have gotten some great advice and coaching along the way. And I think what's really important, since most of the listeners on this podcast are physicians, is it's antithetical to the way we were trained. The way we were trained is you take great care of patients. And whatever, if you go to the literature and you do your research and this is the best thing, then you think this is what we're going to do. And because I've academically proven that
Yeah.
this is the best thing, then we should do it. And what you learn through building and interacting with C suites is there's a lot of competing priorities. And so, this great curriculum of change making, part of it is making these cross professional relationships and starting to get to know your chief operating officer, your chief financial officer, or who reports to them and interacts with them. If they're too far up the food chain for you, who interacts and reports to them and knows what the strategic priorities are, is going to save you so much heartbreak. And I think that's where we see a lot of burnout happen for clinicians, is they have great energies and ideas, but because our training was incredibly focused on clinical medicine, which is amazing, understandable, there's some areas where a lot of times we just don't have the experience, the actual training on what makes a successful pilot or a successful business case. What else have you learned or observed over your years working with clinicians?
It's really adapting technology, adopting change, things like that. The resistance is much greater than most people perceive. One, it's just status quo. It's so much easier just to keep doing what you're doing. Two, a lot of the changes you're going to make aren't really going to pay dividends right away, right? If you put a bill out for patient care, you provide it and you get paid 2, maybe 3 months later, right? If we're talking about what Rely does a lot of, which is readmission programs, that effect may not come in for 18 months when you're looking at the readmission penalty being lowered, right? So everybody would love to see immediate effect of return on investment and things like that. But really understanding that, hey, the administrator that you're asking for that money, is it really sure if they're really going to be here in a year and a half, right? So a
Yeah.
lot of times it's how do I fix my biggest problem that's in front of me today? Much more
Yep.
so than, oh, I just showed you next year you could save $1 million. That's great, but I need that today. So that's probably one of the big learnings is really trying to frame up, okay, how do we get some small wins today that lead up to the big win or the return on investment in the end?
Yeah. I think you've, again, just provided such great language to another problem I see so often is because I say with healthcare, there is no margin. There is no give in the system. The dollars are so tight. And so you can see in most emergency departments, if you have a day where you see 10% more patients than average, that can cripple an emergency department. If you have 10% more admissions than you're expecting, boarding goes up tremendously. So, let alone you put in a COVID-19 or something truly, or even a bad flu season, or 25% or less people getting flu vaccines. All of these things, there is no give in the system. And so, because of that, we all are myopic, right? We can only see what's right here. And so, we have to work really, really hard for those of us who do have some protected time. How can you carve out a little bit of time to look a little bit further down the road and looking at 1 to 2 years down and be able to put some of your attention out of what's in your near vision?
Absolutely. Yeah, that's really the biggest challenge we face now is just how do we make sure we're taking care of the patients in front of us? And there's plenty of them usually, especially in the emergency department. And really that's where the thought usually stops until the end of the shift. And then you're like, wow, if I would have had this or if I would have had that, but then all those patients are right back the next day. So I like the term you're using, protected time. I wish more of the physicians that we worked with had some more of that protected time to really think of how do we make this work better instead of just keeping it dysfunctional in the long run as it is.
Yeah, it's such a great way of describing it is that we spend so much of our energy bootstrapping, being the glue that's filling in the cracks instead of having that time and space to think about how could we do something quite a bit differently, which I think is a good dovetail into the work that you're doing with Rely. Can you tell us a little bit about what Rely is and why a clinician might be interested in it?
Sure. So Rely Health was actually born out of a physician group, a innovation grant through Vituity, and they had a care navigation group. So a lot of their hospitals were asking them to help lower readmission rates and guide patients to the right level of care at the right time. So as you know, a lot of patients show up in the emergency room that aren't really emergent situations. However, they're not connected to care anywhere else. So that's really the foundation of Rely was we had this group of care navigators and they started using this AI-based tool. And that AI-based tool could communicate with patients. It could help them find the right level of care. It made sure when they left the emergency room, it gave them the tools they needed to connect to care outside of the emergency room. So since then, it was mostly a texting messaging tool. And now we built agentic AI that can actually talk to the patients, understand the patients, and help solve a lot of the problems. So a great use case was we had a gentleman out in California. He had an 88% no-show rate for his clinical visits after emergency room follow-up. scheduled the
Wow.
appointments, wanted to go, wanted to get the care, was trying to use the system the right way. Even went through, and with Medi-Cal, there's usually a transportation benefit. He would set up transportation, the car would show up, and then the car would drive off when he came outside. Unfortunately, severely obese and wheelchair bound. And most of the time, the car that showed up was not one that he could get into. So finally, one of our care navigators was talking to him. They're like, why do you have such a high no-show rate? Why do you schedule these appointments and not go? He's like, it's not that I'm not trying. He's like, I am trying. So our navigator got on the phone, got Medi-Cal to approve a handicap accessible ride and be able to get his wheelchair in there, got him to his appointment. And now he's engaged with his PCP. And it is even more important in this case because it's a capitated model, right? So every time he went to the emergency room, it chipped away at that capitated payment that the physician was getting for managing his care. So simple things like that, just making sure that the hurdles are clear for patients to be able to do the right things and helping them schedule appointments, helping them schedule transportation, making sure that their insurance is going to cover it or that they're going to a network provider. Those are the type of things that we built agentic AI to have those conversations and be able to do. Now, the key is we have a human in the loop. So we always have a human sitting in the background, monitoring all the AI conversations. And as soon as it reaches something that our AI agent can't handle, the human will step in. They'll help solve that problem. Like in this situation, they called and said, hey, this patient's really trying, but we need you to step up a little bit and provide a higher level of transportation. We fed that back into the AI and trained the AI on it now. So now the AI knows how to handle that situation as well. So there's this continuous learning loop that we always use. The other guardrail it puts in place is our AI agents aren't going to hallucinate because we always have that QA, that human knowledge sitting behind them, making sure that they're on track with the patients.
Yeah, there's so much to talk about here. One thing I do want to spend a little bit of time and just make sure we level set. Can you explain a little bit more about capitated payments? Because I don't think that's maybe clear to everyone listening how that works.
Sure. So many value-based care plans, managed Medicaid plans, things like that will provide a physician. One, they will assign you a panel of patients. You don't always have control over that. And you've probably never met more than half of them, I think is about the average. So there's patients that are engaged in your practice that you're seeing on a regular basis, which is a fair grounds. It's now your job to manage their care. But you also have all these patients you've never met that don't engage in healthcare, that don't do those things. So that capitated payment, you get a certain payment for each patient on that panel. And it's your job to utilize that money to manage their healthcare as best as possible. Unfortunately, one emergency room visit, one hospital stay will pretty much make that a wash or put you upside down on managing that patient. That's one of the biggest challenges that value-based care is facing right now is how am I
Right.
responsible for patients I've never met?
Mm.
And those are usually the patients that end up costing the most and kind of breaking that value-based care system.
And from your estimation, not that you have a crystal ball in front of you, do you think value based care is going to expand? Is this something that, if you're not already experiencing it, you anticipate? Do you think that's where the market's going?
I can't see it not expanding. There's just no way to continue funding care the way it's currently funded. As typical, a payer is going to try and shift the burden onto the physician and the clinicians and get them to manage the patients better, as if they might have a crystal ball, right? And be able to project when someone's going to get sick or going to go to the emergency room and try and head that off. So it's definitely coming. I don't see any shift or slowing down of the value-based care type arrangements. They'll come in all different forms. You have teams, which is, if you get a hip replacement, whoever does the hip replacement has to manage that patient's care for the next 30 days. And if they readmit it, they don't get reimbursed more for that. There's plenty of programs out there. A lot of them have not stuck. Like I mentioned, when I first came into health to the sales side of things, I was working with Health South. We were trying to become part of bundle payment programs. And that's the exact capitated model I'm talking about. So it's transferring someone from a hospital to an outpatient rehab facility and to a home health company and managing all of those transitions and making sure that patient's health stays healthy and doesn't readmit back to the hospital.
Yeah, and I would refer listeners back to the episode with Dr. Verena Voltaire, and she has a great book out there. It Takes Five to Tango, and then she's written a second book more on the patient experience. And, when you think about how much the United States is spending on healthcare, it's an crazy amount of money. And then you look at the actual health outcomes. And so, from a policy standpoint, you can argue that value based care is probably the best hope, that we have to figure out a way to incentivize instead of a fee for service schedule, which incentivized procedures. Value based care would incentivize what we all claim that we're here to do is try to promote the health of people, but the transition to value based care, and then I would say the fragmentation of our healthcare system contributes to a lot of the difficulty. You think about your average interaction. My window's easiest through the emergency department. They see me. I'm a goody physician in the emergency department. They're at a hospital partner. The hospitalist may be the same or different group, and then the primary care that we're referring them to may or may not be affiliated with the hospital or the physician groups involved. And then the choice in primary care may not be there because whatever their insurance is may dictate that they have to use a certain primary care. And so, what I see a lot of probably, and this has really, I think, gotten much worse in my career, because pretty much my entire career, starting with residency, I would ask patients, who's your primary care? And now the most common answer is, I don't have one, or I don't know.
Yeah. And that physician that they don't know is responsible for their care, which makes no sense whatsoever. But that's really one of the biggest programs that we're usually asked to develop is how do we connect patients out of the emergency room to a primary care home? And it seems so simple, right? You write the note, you tell them to go find a primary care physician, or even, maybe it's a cardiology appointment. Maybe they need to pick up a prescription. Those are all the things that we try and help connect patients to. But that primary care home is one of the biggest components of reducing readmission rates, especially for the high frequency patients that only interact with healthcare when they go to the hospital.
Yeah, I guess I'm a little bit interested in the granularity, because when I've had these conversations with patients in the emergency department, I'll say, I'm taking care of you regardless of your ability to pay today,
Yeah.
but to help you follow up and connect with a primary care, knowing if you have an HMO or a PPO is really helpful. Can you find your insurance card? Because your insurance card may actually have a primary care's name on it. How does Rely do that? Are you connecting with the EMR at the hospital that's feeding that information, so you already know that by the time that you're calling the patient back? Or do you walk the patient through that process?
Sure. Starting at the beginning, as soon as you have your discharge note ready and you explain it to your patient, basically, that's another reason why we always have human in the loop, is that we
Mm.
don't need a technical integration. That human has access to the EHR and they're going to navigate the patient from there. So they will grab the note. You'll explain to them that, hey, we have this free care navigation service that's going to make sure they help schedule your appointments and connect you to care. So with that permission, we'll grab that patient's note. We'll have the AI agent call them the next day. It'll read the note to them. We do have some health literacy components that explain all the diagnoses and your recommendations for that. And then we go from there. So we do have access to that. We'll look at the insurance they have, or if they don't have insurance, we'll look for community programs that we can connect them with. Recently was down in Jacksonville. They have a program called Jack's Cares that will help pay for care, pay clinicians for providing care to those who are uninsured. There's programs like that all around the country, right? And it's just a matter of really digging in and understanding what's available for what patients, and then following that next best step in care.
Yeah, I love this so much. And, I've always thought to myself, the few times I've been truly sick or really injured in my life, and it's so painful. I was so thankful after I broke my arm last year. I thought it was going to be terrible getting a follow up appointment with ortho. And I was very lucky that my healthcare system made it so simple. I was able to hop on a telemedicine call that morning and there were many appointments open. Got the telemedicine, spoke with the family physician. She gave me the phone number, and, I was in the orthopod's office, I think that afternoon, but by a wing and a prayer. And then I was a physician and pretty literate with the system. But, it is heartbreaking. And again, this is what I hear a lot about burnout. I've had a coaching client tell me that the moral injury that she's experiencing by not being able to get patients follow up makes her want to leave the field sooner. We can't lose any more physicians.
Well, you should introduce us to her. We'd love to help. But that's exactly the type of story why we exist. It's clinicians that are doing everything they can, but once that patient leaves the door, they don't know what's
Yep.
going to happen. One
Yep.
component is we will write a note back in the EHR and let that physician know, hey, we took care of your patient. We schedule them with the cardiologist. Here's the date they're going to see them. We schedule them with the PCP. Here's the date they're going to see them. If anyone has any questions, patient or physician, they can call Rely. We can let you know exactly what's happening.
Yeah, that's huge. Well, coming back to our Changemaker framework, we got some of your individual story. You've worked at a lot of different companies and you worked with countless teams at this point. What are some of the tips you have for listeners about when you're trying to make a change and you're building a team or supporting a team through that process?
Sure. Change is difficult. It's not going to be easy. Don't think if anyone's selling you something that they say, oh, yeah, we'll just turn it on. It'll run by itself and you don't have to do anything. That's just almost never true, especially in healthcare. The biggest challenge in healthcare is there's so many people involved in the process that have competing initiatives usually, right? Your case manager's job is to get the patient out as fast as possible, right? The physician's job is to see the patient, write the note, and then move on to the next patient. You only have so many minutes. So all of these things add up to making it very challenging to actually get the change to stick. When I was selling rehab devices, we kind of called it the closet of shame. Almost every rehab facility in the country has this closet of all the pilots they did, all the technologies that they tried out that are now just sitting in the closet because nobody spent the time to nurture that program and to make sure that program carries through. My biggest advice is always, if you're looking for a vendor to provide any service, make sure you're getting humans with it from the vendor to support the process and continuously educate and support your team. If you're going to get a software product or a SaaS product or anything and not need support, that's an immediate red flag.
Yeah, that's, I think, helpful advice. And I think for the listeners of this podcast, like you're probably early adopters, and there is like a published innovation curve. And like most bell curves, if you're at the far right of being an early adopter, most of the people you work with aren't. And so you're going to have to deal with that. And it's the things we found in our paper. It's listening to dissent. It's really sitting there, even though you might think this is the best piece of technology ever, you have to really listen to what their concerns are.
Yeah.
And you also have to find a way to cut through the noise. So we're all like, my email box, I've got probably 200 messages right now. So if you think simply sending an email message is going to get somebody to use a new program, that's not going to work.
Yeah. The biggest thing for us is exactly what you said, figuring out why, because we're always going to see resistance from somebody, right? Whether it's the nurses on the floor, they don't have time for that extra click, whoever it might be, really understanding what their concern is and then seeing if you actually do solve the problem for them. So a lot of times it's like, we don't have time for extra steps. But then in our case, we'll explain to them, well, yes, but this step will take this off of your plate, right? By then we can manage that patient sooner for you. And you can spend more time in front of that patient that needs your personal connection and your empathy instead of sitting at your computer trying to find that appointment, right? So some of those administrative burdens that have just been thrown on clinicians because nobody else is there to do it, we want to remove those so they can get back to being in front of the patient and being attentive with the patient instead of staring at a computer screen trying to solve an administrative type task.
So let's say I'm a patient. I've just been discharged from the hospital with congestive heart failure, and I get a call from Rely to help me get in with my cardiologist. And I hear the voice, and first I'm like, okay, I think this is a human talking to me. Does it say from the beginning, like, hey, you're speaking to an AI agent?
Yeah. So it all starts in the emergency room. We'll have usually a flyer there with a QR code. And all we ask is that you explain to the patient, hey, we have a care navigation service. They're going to call you tomorrow and they're just going to make sure that you have everything you need to continue with this plan of care. And then when they scan the QR code, it actually saves our phone number onto their phone. So when we do call them, it'll say the hospital's name, care navigation service, and it'll be a local phone number. So that's usually the biggest hurdle to get over is, are they going to answer? Right. And then once they do, we do announce, hey, I am, all of our AI agents have names. I'm John. I'm an AI agent for Andrea. And she asked me to give you a call and make sure you understand your care plan. And I'm here to help you schedule any appointments you need, make sure you can pick up your prescriptions, things like that.
And what happens if I go, oh, AI, I can't believe AI called me. Can I say I want to speak to a human or zero?
Yep. Our human navigator picks up right away. So our AI can actually sense when someone's getting disgruntled. So just by the tone of their voice, the language, and it'll alert our navigator to pick up, and then you'll get that human interaction. But as soon as they say they want to talk to a human, we have our care navigator sitting behind all of our AI agents that can interject at that point.
Now that I know companies could do that, I'm really annoyed when the companies that when you're trying, you're on the phone tree and you're like, none of these numbers address the issue that I'm having, or I'm explaining the issue. And it's like it doesn't fit into any of these neat boxes, and you just keep getting stuck in the phone tree.
Yeah.
Well, there's probably a recording of some pretty terse things that I've said in those situations because it's awful. And you
Yeah.
can imagine someone sick that's stuck in a phone tree, how frustrating that would be. So I'm really glad that what you just mentioned there, the human in the loop, to know that it's truly there, or that human, he, she, they is there all the
Yeah.
time.
Interesting you bring that up because we've been talking about the hospital side a lot. We also do replace phone trees with AI front desk agents for physician offices. One of the physician offices we work with now is an oncology practice out in California. And if you call in there, it'll be an AI agent. And all you have to do is tell it what you're trying to do. Right. And they had this issue where they had 8 or 10 options on their phone tree. And people would just click till they got a human because they needed to ask somebody a question. Now, if you ask our AI agent, you say, I need radiation oncology. Most people don't know that it's radiation oncology, right? I just want to talk to the nurse. I just want to talk to the doctor. Our agent will get you to the correct place. So that's probably the easiest entry point. Very low risk, very low clinical interaction. If you're looking to explore AI, that's a great way to do it. Have an agent be able to answer the phone and route those calls for you. And imagine the burden that takes off everybody's shoulders. So not just the person that's answering the phone that's getting yelled at all day, but also everybody in the back office that is getting transferred calls that aren't for them. And they're getting distracted from working with their patients or entering information in the EHR because their phone tree is really not working. So that's a great upgrade use case for AI that helps simplify a lot of these larger, more complex phone trees.
I am just going to put it out in the universe as a veteran that does get some of my care at the VA. I really hope Rely gets a contract with the VA because it's terrible. Literally, if I need to call and speak to a human, I usually set aside 30 to 60 minutes, or that I have my phone on speaker and that I can be doing emails or something while I'm trying to get through. It is unbelievable how cumbersome the VA system is when it comes to simple tasks of making appointments and getting follow up. And the VA is actually the largest healthcare system in the United States. So I'm going to put it out there. That would be a huge win for veterans. I would take an AI agent. I don't know if it's training or what, but a lot of times when you do interact with clerical staff at the VA, it's incredibly painful.
And it's a human capital issue, right? Anytime we've needed somebody to do a task like that, they've just throw more bodies at it. And it's a very difficult job, right? People have waited 30, 45 minutes because there's just not enough of them to answer calls efficiently. So people are already frustrated, right? So
Right.
imagine sitting on the other side of that phone where everyone you talk to is frustrated and upset with you, and all you're trying to do is the job you were hired for. So it solves a problem on both sides. And it's just something that humans shouldn't have to do. If I'm an empathetic human, I should be interacting with humans, not just that need to be transferred to another number, but helping them try and solve some of their problems. So that's what we really try and do is have the AI agents do everything that doesn't take human interaction. So if you just need to change an appointment, you can tell the AI agent, I have an appointment this time, I need to change it. It'll take that information and feed it to those people in the background that can actually change the appointment for you. Some of our agents can actually do the appointment change for you, depending on the access we have to the EHR. But the idea is we're putting people in a difficult situation already. And then we're having frustrated patients that have waited 30 or 45 minutes to try and do something simple. The likelihood of that going successfully is pretty low.
Yeah. And I would also say, from a patient experience standpoint, it's incredibly frustrating to be in person. I took the time to come to this appointment. I'm here, and now I need to make another appointment or whatever task. And now I'm waiting because they're on the phone,
Yeah.
transferring a call. So I just really think, from a patient experience standpoint, for your patients that are actually in your lobby, that are right there, to take off some of that administrative burden. So for the patients that are there, your staff can actually be there for them.
Yeah, very similarly for physicians with ambient scribing, right? You mentioned Savant, I think when we were talking before the show, and that's the exact same thing, right? We want the physician to be face to face with a patient, not taking notes, not trying to type everything out. So let's get our clinicians that are highly trained in interacting with patients. Let's have our humans interact with patients and show that empathy. And let's let technology do everything else.
Yeah. Well, this time has just flown by. Was there a question I didn't ask, or something you'd like to get across to the listener about technology, innovation, rely?
I just say if you're out there exploring, be ready to invest your time and your effort into something. Don't waste your time doing a pilot if you're not truly invested in turning it into a long-term solution. I think so many clinicians, so many even C-suites get so burnt out because they see all these solutions, all these pilots coming through that weren't thought out. And usually that gap is somewhere between that excited champion that wants to adopt every technology and what's actually going on in the hospital or at the practice. So just like we said before, make sure you pull everybody together. Make sure you're building relationships with your COO, with your CFO, with your chief clinical officer, with your quality team. All of those relationships will pay dividends in the long run when you do want to make a change and when you do want to adopt a new technology.
Yeah. So more slowing down in the beginning phases, relationship building, letting people poke holes in your idea. And as uncomfortable as that is, it may save you a lot of heartache earlier.
Yeah, from the commercial side of things, it's painful for me to say that because I don't want things to go slower, but I don't want to do 100 pilots to get one successful program stood up either. So that's one of the biggest things I do in our process is just one, identify, hey, this is a good fit or it's not, or help folks make those connections and try and get the right answers before we invest a lot of time in a pilot that a lot of times just never really had a chance.
Yeah. Awesome. So, a couple other things we like to leave the audience with, kind of our quick hits. Is there a mantra or quote or phrase you say to yourself when things get tough?
The mantra I always go back to anywhere in healthcare is just pretend it's your parents, right? How would I want my parents to be treated? How would I want my parents to be handled in this situation? And it changes perspective pretty quick, I think, for a lot of folks. You get caught in the day to day and you're moving patients through. You have 8 minutes to see this patient. You got to get a discharge out. This patient's been here for 3 days. I got to find a skilled nursing facility. Let's just put them there. So some of those things, if you think about it, how would I want my parents treated? Helps you slow down a little bit and helps you usually make the right decision and connect patients to the best place for care for them.
Is there a conference that you've attended, maybe in the business or innovation or technology space, that you think if somebody's activated, they're learning about AI, they're learning about this technology that might fill their cup?
The big conferences are great places to go to meet people, to network, to have very low level conversations, which is good. You need to do that. You need to network and you need to learn about things. But if you're really trying to dig in, you want to find a conference that is probably, I'd say 150, 200 people attending for a very specific topic. So be very selective about where you go. Make sure the speakers are people that you would take advice from, right? So do your research there as well. You show up at a conference and it's folks that you wouldn't listen to their advice normally. Why would you pay to go listen to them speak? Right. It's doing a little bit more homework up front. Don't just look at the topic, but look at what types of discussions they're planning on having. Look at the programs of the presenters that they've launched at their own hospitals, right? If you have a speaker coming in talking about AI, yet you look at their hospital and they're in the dark ages, that might not make a whole lot of sense, because understanding AI and wanting to use AI, as we just discussed, is very different than actually knowing how to implement a program and make it successful.
That's great advice. So, for any of our listeners that are interested in connecting with you, perhaps learning more about Rely, what's the best way to connect?
Sure. LinkedIn is a great way to get a hold of me. You can DM me there anytime, readily available and always on there throughout the day. Relyhealth.care. You can also just fill out the contact me form and I'll follow up with you as quickly as I can.
That's great. Yeah. So, for the listeners that aren't on LinkedIn, I would really encourage you to consider it. I found LinkedIn to be an incredible space. It truly is a professional space. And I found the interactions to be uplifting, supportive, and also intellectually expanding. So I think that's a great call to action. If you haven't been on LinkedIn in a while, or maybe go on, update your profile a little bit, and maybe make Dale one of your first connections. So, Dale, I want to thank you. It's been a real pleasure getting to know you over the last 6 months. And I really value the years that you've spent in the healthcare and business and innovation space, and that you get the clinician perspective and truly are here to help us. So I think we don't have to go at it alone. As Dr. Linda Lawrence has said many times on this podcast, there's people like Dale that want to listen and hear what the clinician problems are and try to help us solve them.
Yeah, I appreciate that. Thank you for having me. And one of the things that I always tell any of the sales reps that I bring on, especially some of the younger ones that are just getting into healthcare, is make sure you end every call with a solution for somebody. It may not be yours. There may not be great alignment with what I do, but I've spent a lot of time building a network of other solutions, and I'm happy to refer you on or help guide you to something that might solve the problem if I can.
Yeah, that's a great way to end. A rising tide lifts all boats, and we need all the help that we can in healthcare.
Yes. Excellent.
All right. Thank you, Dale.
Thank you. I enjoyed it.